Welcome to the Murfreesboro.com podcast, where we talk about all things Murfreesboro, Tennessee. Join host John I. Carey, his co-host Jonathan Harmon, and producer Trent Denson as they talk about all the great things happening in our city. From construction updates to local business spotlights to all the amazing events happening in our community. Listen in for all you need to know from Murfreesboro.com. Welcome to the show.
All right, good morning, everybody. Welcome to the Murfreesboro.com podcast 2.0. I am Jonathan Harmon. This is John I. Carey.
Morning.
I'm changing it up a little bit so you get to hear me first. I'm so sorry to hear that, or for you to hear that.
You're way more well-spoken than I am.
Yeah,
so.
I don't know about that. You like people more than I do, though. So that
I do like people. Yes.
Yeah, that's true. So, John, we're just going to cut to it because we got a lot on the plate here. But with the situation we find ourselves in currently, we just thought it was a wise decision to get to straight from the horse's mouth kind of thing guests on. So Dr. Arelli and nurse leader Gideon. See, I'm working on that whole thing, right? And you guys are at TriStar StoneCrest here in Rutherford County. And
thank you, TriStar, by the way.
Yes,
Carrie's off camera over here.
We have a live studio audience.
We do. There's actually people back over here. It's kind of neat. So.
Boy,
yes. Sound effects.
Love it. And so what we want to do is we really want to. We took a ton of questions. John posted this a few days ago to just get questions to ask the experts. And I think that one of the most challenging things with the situation we're in is that this social media situation. On one hand, it's wonderful. It connects people. It gets information out very rapidly sometimes. I mean, it's great on one side, but then the dark side of that is, I didn't mean the dark side, and I pointed at John. I just realized that is that it also can work for the other side where it spreads disinformation, and it's difficult sometimes for people to know, believe this source and don't believe this source, and then. If you've ever watched The Social Dilemma, you get into all the algorithms where it starts making things stickier and all. Anyway, it's mind-blowing, blogging.
Blogging? We'll go with that.
Yeah, okay. Anyway, so we really wanted to get you guys in here from the front lines, the people that are in the rooms every day, that are researching it, that know. Mm-hmm. And I want to start with this. So as John was asking for questions, and he got completely inundated with questions, but we did have a few folks that stated, we don't have a question, but here's the direct quote, no questions, but I would like to say thank you in all caps, which means she yelled it at you, to the staff for all you were doing. So that came from Amy Harmon. So anyway, she said big thanks there. And then Cindy... How do you say it?
I don't know on that one. Krawiec.
Yeah,
thank you, Cindy K.
She said, pass on my thanks. I had great care there last week. So, satisfied customer, 5 stars.
There you go. Yeah, there you go.
Appreciate the thanks.
Or should it be 3 since it's TriStar?
Yeah,
we'll go with 5.
We'll go. There we go. Awesome. And also thank you to all the people that responded. I mean, we were inundated with questions, and there were a lot of questions that were very, very similar. So for those watching and listening, if we didn't call your name or your question out directly, it's because there was another one just like it, something like that. So we're trying to condense them down as much as we could. But
before we get too deep into some of the stuff about Delta and Corona and all the different words for it, I thought this was a really good question, and this speaks as much to you guys as it does to just the hospital in general. And Heather McCrate says, if I or a loved one have a non-COVID emergency, will we still get quality care, or is the hospital too overwhelmed? And I've heard that a lot, right? Like, I don't even know why I want to go to the hospital. They're so covered up with COVID right now. Will I even get care for my broken arm or, heart attack or whatever, right? So how do you guys want to speak to that one?
I would say absolutely. We're not just taking care of COVID patients. We do have a lot of them there, but we take care of everybody that comes in through the ER. We make room if we have room. If we don't have room, then we send them somewhere that does have room if they need to be admitted.
And what happens when there is no room?
We hold them in the ER and take care of them as best we can.
Okay.
If they can't go home.
I would actually encourage people to come in if there is a situation that they feel requires medical attention, because we have seen the opposite when people have actually held off and held off and held off And by the time they come in, they're really sick.
Yeah.
And they're at a point where we are really limited with what we do, not because of resources, but because you've actually gotten to a point where we cannot help you. The heart attack's been going on for too long. And the
strokes and
correct.
Yeah, I mean, stroke responses.
Yeah. Correct.
The faster the better, right?
Correct. So, or they're letting another infection take place, and they thought they could manage it at home. By the time they come in, they need a surgery, or they need to be in the ICU for something called septic shock, which is overwhelming infection of the body. So, we encourage people to come if they are having a medical disorder or syndrome or anything that requires attention. We'd rather go ahead and tell you in the emergency room or in the hospital, this is something that we can be managed at home. Let's address what we need to, and then we'll send you back home at that point.
Well, and if nothing else, it gives you a documentation point, right? It says, okay, here's where you are. So now we know in a week it's getting better, it's not getting better,
Correct.
whatever.
Correct.
All right.
Cool.
Wonderful. Thank you for that. We had another question from a gentleman named Barry Campbell. Very simple. He just was curious: is there are there two different tests to test for the Delta variant and Corona, or is it like one test tests all, or how does that work exactly?
So I think that there are almost multiple questions that came out of this question to me.
Okay.
First, that we always talk about the rapid test, and then we talk about the PCR test. And it's not just necessarily that the rapid test is accurate or inaccurate. It's really a lot of it is technique. Our nurses know how to really perform the test accurately. And that sounds somewhat silly to state it, but it's not. I mean, if you're not getting a good sample, you're not going to get a good result.
That makes
sense.
sense.
So we have actually had situations, you can probably quote more than I can, where they come in negative and then they're positive when we retest them.
And we know. We know that we feel like we know that they're positive just by looking at their symptoms and then the way they're acting and everything like that. So if they come back with a negative test, then we retest them. And oftentimes they come back positive.
Are you seeing more of that with the availability of the home test kits and all of that?
Yeah,
I can't speak to that. I don't really know. I haven't had a lot of patients tell me that they tested it at home. So
we've had a few.
I was wondering about that with the home test. I mean, how accurate is it, or how, whatever the swab technique, how far are they really going to go back and stuff like that?
I, in my opinion, I would doubt that people go back as far as they need to at home. It's not comfortable.
Yeah, because when I initially had the one done, we did a video on it forever. I think she poked my brain.
Yeah,
That's what
we always say, go to the back of the brain, and then we know we're far enough.
It's not going to be
Yeah,
accurate.
I think my eyeball was about to go boop.
Yeah.
So to your point, the test is only as good as the sample. So unless there's an innate flaw in the test itself, it really comes down to the sample.
Correct. And then in answering the second part of this, as a physician, it doesn't change my management. Whether you have Delta, whether you've had another variant or a new variant that's coming, it doesn't change our approach. We don't use different medications. We're not approaching this from a different perspective. It's all COVID-19. So I think at larger centers that are academic-based and that are doing research, they probably want to be able to delineate what is the percentage so they can give some actual data to the CDC, to Tennessee.gov, all this information. But from a perspective of treating them, it does not, we have never thought at any point, oh, this variant is what's coming in. It's going to be this approach. It's all the same.
Got it. All right, that was a very detailed answer. Thank you. That was great.
She's very good at that.
I think you stated actually things very well.
Awesome. What's the next one you got for us?
Let's just start going down the list.
Let's
Is there a percentage, a number, whatever, or even just some anecdotal numbers there as far as folks who were admitted for other health issues, diabetes, stroke, heart disease, whatever, and then they end up being tested for COVID, and that, I'll stretch the question. That's where their question stops. But how do you triage that? I mean, obviously you got to save a life if there's a heart attack or a stroke or whatever. But then, at what point does treatment for that kind of take a backseat to, oh, holy cow, they can't breathe? You know what I mean?
I think you've seen some of these also, so quite a few.
We triage them by how sick they are. We have patients come in several times for other conditions that we test. In our ICU, we test all the patients, no matter what, because it's highly transmittable, and we don't want to get really, really sick patients even more sick.
Right.
So they could come in for a DKA, diabetic ketoacidosis, have to be on an insulin drip, and we're going to test them whether they're symptomatic or not for COVID. Some may come back positive, some may not. Not all of them show symptoms. Mm-hmm. So we triage them by how sick they are. And,
What's the most pressing issue at the moment, and then if you discover
Well, we
something?
would treat them both. I mean, like, so you mean like if a DKA patient came in, what's more pressing, the COVID or the DKA? Both of them. I mean, we're gonna treat them both.
You can do them at the same time.
Oh, yeah.
Okay.
Oh, yeah.
Yeah.
And sometimes COVID might have, in that situation, caused the diabetic ketoacidosis. For example, if you're having a lot of diarrhea or you're throwing up from it, then you're losing a lot of fluids, you're not able to eat, and then people are not taking their insulin appropriately because they don't feel good and they don't really know why. And then they come in and then we figure out, oh, this is what happened. This is kind of the back data.
I see.
Gotcha. Okay.
Makes sense.
Oh, okay. And then Miss Britt Moore asked, she was curious if families have, if they would request to not have the treatment and they want things like specific treatments, including things like high dose intravenous vitamins or excluding things like intubation. What do you do with the families that possibly may want some other treatment?
So this is something I think we approach with our patients every time. I just want to kind of give a little caveat. In the medical world, we've really moved away from paternalism in medicine and like, I know best.
Yeah.
And it's more shared decision making. So we're here to give information, and together we're going to make this decision. So I will add just a little bit to this question that we will honor the patient's wishes, whatever the wishes the patient wants. And then when the family has more specific information or questions, it's still what the patient wants. So is this what the patient would have wanted? Is this what he or she told you? You are the voice for this patient, but we're going to honor what they feel is best. And then the old adage in medicine, first do no harm. So though there are requests for different medications, we have to look at the data and the literature and the evidence and say, this actually does not help you. And in fact, it could harm you. So we're not going to do this treatment that seems like something that we talk about social media that you might have read on whatever social media site. We're going to go to the trials that have had thousands or millions of people, and we've been able to collect data and say, this is what works and this is what doesn't. That's because I don't know about anyone else outside of the medical world who feels differently about this. We approach our patients like they're our family. What works for you is what I'm thinking is going to work for me. I'm not going to offer you something that I'm not going to do myself.
And if my mom was laying in that bed, this is what I would do. Yeah.
I don't know if you have anything.
No, you said it all.
Now, so let's go a slightly different direction with that same question. How are you guys, just you specifically, kind of personally dealing with the extremely wide panoply of information that's out there that's, and I'm sure you get into conversations and people are like, well, I read that this and I read that this and I've done my research and whatever. How do you personally handle that, deal with that? Because obviously you have done the research and you are reading the accurate information, or the most accurate at the moment anyway.
So that's something that we've dealt with in the medical world even before COVID-19.
Sure.
I mean, as soon as there was
sure.
Google,
Yeah.
people could look stuff
Well,
up.
I read this study.
WebMD.
That,
And the first thing I'll say is I applaud all of our patients who want to know more. So if you come to me as a physician, say, this is what I read. Okay, great. You're really trying to understand what's happening to your body. That's fantastic. Let's continue to talk about the right source to go to get that information. It's not this source, it's this source. And it's not because I'm a doctor and I know better. It's because this is the one that has been validated. And not just by me, by other people. But I think, well, I don't think I know. You guys definitely get a lot more of these questions, and they are fielding them before they even come to us as physicians. So
The treatments what I would tell a patient if they ask me if high dose. I'm sorry, are we on this question right here?
just generally.
oh, it just said high dose
Intravenous vitamins.
or if they wanted to exclude like intubation or something.
Well, what we're using that the physicians have done the research that will work, that we've seen help. That's what we use. If I tell a patient that they want to have some, if the patient tells me that they want some specific type of treatment, I'll ask the doctor. If the doctor thinks that it might work, then I'll tell the patient that we can do that. But it's all up to the physician's discretion.
Okay. All right. Well, I think I'm going to skip the next one and come back to it. We'll do that one. But and actually the next two, because those are it's very specific. We'll get back to those. But there was one, it was Denise Mann. She just wrote in and said, how do you know who has COVID and who has the Delta variant versus, she said her mom got COVID and her sister got vaccinated, but she still got the Delta variant from her mom. Is there a way to tell, like, outside of testing, and you can just tell them, you had mentioned something about the symptoms they had and you treat them, like, can you go, you have this, you have this. Is there a way to tell? Or?
The symptoms are the same. I mean, you have COVID.
Yeah.
As far as whether it's a Delta or the one before that, we, like she said before, we treat them the same.
Yeah.
So from my point of view, from what I see, is I just see that they're positive for COVID.
Yeah. So in a nutshell, and this is, again, I'm just being naive here, you have to excuse me this question, but if they have either one, you've got COVID. Like,
Correct.
you're okay, got it.
It's sort of like the whole flu variant each year, right? You've got
Changes.
A, B, whatever, and it's like, well, you got flu.
And I think, just to add one more thing to this question, because it's about vaccination and they got COVID, I think it's important to distinguish between breakthrough infections and breakthrough hospitalizations. So there are always going to be breakthrough infections for anything. For measles, if you had MMR, for the flu, if you got the flu shot. The question is really not necessarily that you're going to get the virus. It's more, what is it going to do to your body? And that's what we're seeing, is we're not seeing a large proportion of breakthrough hospitalizations for patients who are vaccinated. And the level of people who are getting breakthrough infections is still higher for people who are not vaccinated. Not just infections.
I read something. Here I go. I'm saying what I was already talking about. But it seemed like a really good explanation of this, is that the virus, whether you're vaccinated or not, the virus is on you and can be in it, like your orifices, right? The difference is whether or not you're going to be, the disease portion of it is once it gets into the bloodstream and starts racking your body.
That's a good way of putting it.
And so this said that, vaccinated or not, it can sit at the back of your throat. And the explanation was that's why flu mist exists, but it's not necessarily good at killing an entire strain, right? It's okay to protect you from the outside. But what this guy equated it to, he said it's sort of like if the virus is an intruder in your home and the back of your throat is the front door, right? If you have the vaccination, there's a guy on the other side of that door with a 12 gauge. And if you don't, then they just come in and do whatever they want.
That's excellent. That's actually an
I like
excellent
that one.
analogy.
I'm going to use that. Yeah.
That's a great
Well
one.
put.
I've tried to think of different ones, but that's actually probably the best analogy I've heard.
Yeah. Well, you get the visual shotgun. Come on, let's go.
Yeah, bring it on, baby.
Use that one with your patients. Quote Jonathan Harmon.
No, not me. I'll send you the article. It was really good.
No, I like that. That's awesome. There was one here by Reba. I actually like this one. It was she said, how are people able to treat, or it says right here, is your facility addressing parasomnia, lack of smell and taste from people that have contracted COVID? She personally had COVID over a year ago, and she has been vaccinated, but she's still dealing with that long-term symptom. Is that ever going to come back for her?
I'm a cosign on that. I had it in November of last year, and I've been vaccinated, and I still don't smell very well. Taste is okay, but smell not so much.
Losing your taste and smell is not a life-threatening symptom.
Sure.
I think it's like top of our priorities. So
I don't know, dude. Biscuits smell so good.
Yeah, that's what they do. No, I mean we treat the symptoms that, in my opinion, we treat the symptoms that are life-threatening. That's a very minor symptom that
In the grand
isn't
scheme
really
of
a
things.
concern of us at the hospital,
Yeah.
in my opinion.
Just my own curiosity. Have there been any studies y'all have seen or anything about people have studied that? Like, some people lose it permanently, or something? Can you get it back?
So I think another good analogy is we're building this plane as we're flying it. So we're getting data in real time.
Yeah.
So,
I wrote that down up here.
and we're understanding from our patients. I mean, unfortunately, if you get COVID-19, you're part of the test subjects. You're part of this unfortunate experimentation on mankind that's happening.
Yeah.
And we're getting information from you.
And I think that's the most frustrating thing about this scenario. I mean, we look at vaccinations for polio. We look at vaccinations for, all the different vaccines that have ever existed. And we look at diseases that have been treated for years and years and years and years and years. And the common wisdom now is the end result of years and years of research. Well, it seems like constantly wear a mask, don't wear a mask, do this, don't do this, 6 feet, 8 feet, 2 feet, whatever. And it's like, they don't know what they're doing. It's constantly changing. And the reality is we're watching the scientific method play out in real time.
Absolutely.
While we're living in it.
Absolutely. And this virus is, it's a terrorist to the human body. I mean, it's incredibly intelligent. It knows how to survive. It knows how to.
I just got chills. Thanks a lot.
Yeah, right.
Sorry. Whatever defenses we put up, it finds a way around it, and that's where the Delta variant came from.
Yeah.
I mean, so it's hard to work and to be one step ahead of something that has literally plagued us for 18 months. So you're absolutely right. This is scientific method unfolding, and I think that's where people have to understand science as far as it's really art of investigating the truth. It's not perfection, and that's where we go back and review data for things that are centuries old and maybe 5 days old, and we'll say, this didn't work. We're going to do this because we're always trying to achieve perfection. We're always trying to make it better. So with COVID-19, we're trying every day to make it better. How can we make this less of, a virus that's going to terrorize your body? What's the next thing we can do? So you're right, and it's frustrating for people to have a moving target, but that's because this virus is moving.
Well, and essentially we're waiting on people way smarter than me to have aha moments. And you can't just walk up to somebody, you need to figure this out right now. I mean, it's just not going to happen, Go take another shower, because that's where I do my best thinking, But,
The light bulb moments in the
right.
shower, that's what it's called. That's and it's just kind of a side comment. That's really a two-pronged thing. I find it fascinating, though, how you just said, the virus is smart. It mutates, it changes, it does things, that we're learning to fight. But kudos to the humans that, we're changing and fighting back and all that. We have the technology to be able to do so. But like you said, we're living this moment right now. We got to experiment. We got to try things. But the fact that we have the ability to do that. I mean, think about if this happened, 100 years ago or whatever. I mean, just wipe out the planet or whatever. That's an extreme comment. But I'm just saying.
You're right. We had that with the Spanish flu.
Yeah.
And it was devastating at that time. And that's what we're trying not to relive that. We're trying to learn from our experiences. And that's what we're hoping doesn't continue. The difference is right now, this virus is just, it's the most intelligent virus we've ever come across. So.
Wow.
And if you don't mind, I'm going to switch gears just a little bit, because there were a ton of questions from parents that had questions related to their kids and schools and stuff like that. And one of them, excuse me, it's in here, but it was verbatim. She was saying, if you were asked to go in front of, say the school board and give a recommendation, on not what they should do, but more the facts behind everything, what kind of, what would you say based on the experience you've had?
Sure. Mask work.
Okay.
It's just plain and simple. And it's not because there is a lot of science or logic behind it. We used this before COVID. I mean, even back in the day when people come with like a sniffle and pre-COVID, it was a common thing in the medical world. Automatically, the nurse or the physician or whoever would come in wearing a mask, we just assume, oh, you have a common cold. Forget even COVID-19. You have a common cold, and you have the courtesy not to spread it to our patients who are not going to die from the common cold. That's kind of always been what we've used. And then in the operating rooms and in sterile conditions, we all wear a mask because we don't want to have any chance of passing on the droplets that's in our mouth. And we don't have an infection. We don't have the common cold. We're walking in here healthy. And that's where we have seen that we're not passing on any kind of not dangerous.
What about the type of mask, though? Because, I mean, that's always the question. Well, yeah, that makes sense if it's an N95 or whatever. But, I mean, cloth mask, I mean, when you're talking about an entire population.
Or like a face shield I've seen.
Yeah, you do what you got to do, I guess. But
yeah, so the face shields, they can, if they cover your whole face, they can help you with the droplets from your mouth, but they're more for like eye protection.
Okay, got
droplets getting into your eyes or
Okay.
anything like that. The cloth masks, any kind of mask is better than no mask at all. The N95s we generally use to protect in rooms where patients are on high flow oxygen or on a BiPAP, or they're ventilated, or they're getting a breathing treatment where it can be aerosolized and spread out through the room, airborne and not droplet anymore. We use N95s. They're not necessary out in the world, I don't think. You can just use a regular mask for that. So
just a little, and I completely agree with you, Gideon, on that one. The mask that we wear as in the public or in the hospital that are surgical masks, that is to protect you from me. So that's really what the whole logic is behind that. But N95 is when we're in a higher critical situation with aerosolization, and we're trying to protect the people in the room from you who has COVID-19. Because you're not wearing a mask. You're a patient in the room. You're intubated. We're not going to ask you at that point to protect me from you. But we are going to ask the public to protect each other by wearing a surgical mask from me to you. So that's where I think there's this confusion. I mean, if everyone could get an N95, that would be fantastic. But it's just not feasible or
It's not
available.
practical.
Gotcha.
We would have a shortage again.
Yes, we'd have a shortage.
Oh yeah, again, there you
Again,
go. Yeah. And there was another one with the schools from where a lady was curious. She said, if for the parents that have young children that are high medical risk for COVID, what do you have any recommendations or advice for them with it involving their kid going to school?
Sure. I'm a parent, and before I wear the hat of a doctor, I'm a mom and a wife. So I completely understand where this question is coming from. Right now, there has been this somewhat unfounded rumor that kids are not as sick. They don't get as sick. And it's because I think we were protecting things so early on that we weren't seeing the effects of that. School shut down. The world shut down. We were seeing it more in the elderly, and people were isolating earlier. They were socially distancing more. They were wearing masks more. So I don't know if we really had a real situation at that time. Now we do. Things are open. People are not necessarily quarantining as much, or they don't necessarily feel like they need to wear the mask. It's just a totally different situation where everyone's kind of playing by their own rules, unfortunately, to a certain extent. So I think we're seeing things play out in real time. And unfortunately, what's happening is not just COVID, but all the things that happen in the wintertime for children are happening now because they aren't wearing the mask anymore.
And so correct me if I'm wrong, but flu season was practically non-existent compared to previous years, correct?
I don't even think we had. I can't even think of on my hand like how many cases of flu we had this past year.
I
I
mentioned,
didn't have any. I know that.
yeah, I mentioned
Wow.
this to my primary care, and he goes, yeah, masks work. He goes, for the first time ever, everybody listened to us about masks, and it stopped the flu, essentially.
Yes.
It protected you from more than just COVID-19.
Right.
And that's where children, unfortunately, are now having a double whammy because all the things that we had protected them from, like RSV, typical.
Yes, I have
Huge,
a
huge-
family member that has that right now.
huge
He's
uptake in
14.
that. Correct.
So what the heck? You don't get RSV at 14.
What you get, and that's the concern is now they're getting RSV and then COVID. So now you're really overwhelming the body. These are little kids, so it's hard for them to be able to mount an immune response that's reasonable, especially if they're really little. So.
There was another, but with the flu involved, there's another question. The lady was just curious: is it necessary to get the flu shot as well as the COVID shot? Since
Yes.
Okay,
It's
yeah,
two completely different viruses.
that's what I was figuring, but
Yeah.
she was curious because of what happened, and we didn't have any flu cases. Oh, well, you still need to get the shot. So
Right.
okay,
I would say yes.
What are you guys seeing predict the future a little bit for us? So the whole booster thing, and is that gonna help with Delta? Is it necessary? Like, if everybody does, I mean, heck, if everybody would get the first round, that would be great. But what are you guys thinking on the booster front?
I think it's necessary at this point. And again, it's because we're seeing the scientific method unfold in real time. And I think one of the concerns that people have is, well, the vaccines came out very quickly and we don't really know if we have a lot of data on it. But now we have a lot of data on it. Millions of people have gotten the vaccine and we're seeing it work and we're seeing it play out in real time. So we don't necessarily know how long it's going to give you that protection because now we have a virus that's exquisitely smart and is finding other ways to mount an offense to our defense in some ways. So we're expecting the worst. So I think the one thing COVID-19 has taught us is we can't predict it. So if there's a chance for things to be even a little bit improved in the medical world, take it. So if the booster's coming through, this is definitely the next step. And by the way, this has now been something that the FDA has now authorized as stating is the next thing to do is to get the booster. On a personal experience, I have a family member who's immunocompromised who I already arranged to get the booster. So I think we're all in line to get it if they get when we're supposed to get it. Yes.
Oh, perfect. Okay, that was probably. I was actually going to ask that because I don't know how, but I dodged the bullet several times, and I had many interactions with people that called me. Thanks, John. No, I'm just kidding. Had to mess with you for a minute. Yeah, but that said they tested, and
hey man, that's an uncomfortable phone call, by the way.
I was just messing with you, John. but that said they had tested positive, and so I went and tested, and I'm vaccinated and everything, but 4 different times, well 5 times now, and I've tested negative every time. I mean, my wife got it, and I still tested negative. So you're talking about the vaccine working. Should I still go get the booster shot? I mean, just regardless.
Definitely right now for those who are older and immunocompromised, that's a very broad statement. There's almost some level of wiggle room to that, but it's really those that you think are a higher susceptibility of essentially dying. So if you seem like you're a higher risk, it makes perfect sense. Yeah. And those people were the first ones to get the vaccine. So again, we're trying to make sure that we are helping the body mount as good of a response as possible.
Okay.
I'm going to go rapid fire with a few of these, if that's okay. So, percentage in the hospital right now, vaccinated versus unvaccinated. Just shooting from the hip. I
can't speak to percentages. I know that the majority that we have are unvaccinated.
Okay. And how many reinfections are you guys seeing? Is that a thing right now? I had it in November. I have it again now.
You can get it more than once. I mean, it is possible. I couldn't tell you how many though. I don't know.
Okay, and the question, the kind of second part of that question is, if I've had it, why do I need a vaccination? Because isn't it supposed to accomplish essentially the same thing?
So, when people get COVID-19, their symptomology or the symptoms can change from every time they've gotten it, and we've seen this sometimes when people come back in with COVID-19. They're like, oh, the first time I just had gastrointestinal symptoms, I just had diarrhea, and now I can't breathe. So it doesn't necessarily mean that your immune system is as involved as we like for it to be, because this virus, the first one that you had could have been this variant, and now you were infected with another variant. So your actual symptoms is going to be different because of the variant. We know the vaccine is holding really good against a majority of them as proof. I mean, we ourselves are around COVID patients all day long, and we're seeing that it's holding. So.
And how many folks you said that a lot of the folks that are coming into the hospital are unvaccinated, but how many of them also have some other type of underlying issue? In other words, the flip side of that is how many otherwise healthy people that are unvaccinated are still ending up in the hospital?
Most of the patients I've taken care of all have underlying health conditions. I mean, I don't think I've taken care of one patient who is just COVID.
Gotcha.
They usually have something else going on.
Okay.
But it is possible, of course.
Me personally, I'm only just one nurse in the whole hospital. So
right.
Gotcha.
Doc, what do you think?
We've seen a majority, we've seen this kind of pan out over the year, or over the past 18 months. Initially was the elderly, and so we assumed you're kind of a little more immunocompromised, or you have cancer with this, or you have something else with this, and now we're seeing the age drop, and we're seeing it drop, and we're seeing it drop. So there's 20, 30, 40-year-olds. Yes, they might be a little more compromised, but they're not by no means the same situation as a 7-year-old who has the same actual disease process. And then we've seen some people who really don't have a lot of immunocompromised state or comorbidities, who are not vaccinated, who are young, who are fairly healthy, who are really, really ill.
Who thought that they could never get it and then did.
Right.
And
do you run into that a lot with people like, I don't need this, I'm fine?
Yeah.
Do you?
Yeah.
Okay.
Oh, yeah. I've talked to several people, several patients in the hospital who do have it, who didn't believe in the vaccine. And you can kind of see it on their faces how they regretted it. So,
yeah, there's a local celebrity that kind of his last address, he passed away over the weekend, and his last address was essentially jump in the lifeboat that I didn't take. So, is there any, somebody wants to, I guess they're kind of, Emily Frazier's kind of basically asking which vaccine. So is there any research showing when they get in the hospital which vaccine they had if they are vaccinated?
So when we screen them when they get to the hospital, we ask them, have you been vaccinated? Yes, you have. Which vaccination did you get? When did you get them? So we are gathering data on that. from our point.
Okay.
Yeah.
And also to extend on that, a big thank you to TriStar StoneCrest, who I will post this on the website as well. You all have provided a laundry list of references for information if people wanted to get more information from very reputable sources. So thank you all, and thank you, Carrie, for helping me with that. But so I'll post that on the website. So if you all want to read more about it, you can. So, but anyways, I just wanted to throw that out there based on info. So more questions.
And that's, I think that's important, is that where are we getting our information from? Is this actually reliable, science-based information? So thank you guys again for supplying some of that, some light reading for everybody out there. My last question is, why do I need to wear a mask in public if I've been vaccinated and had COVID, right? So theoretically, I've got the super antibodies pumping through my veins right now. Why do I still need to wear a mask?
Because you can still get it. I mean, it protects you. It protects you against mortality, protects you against the severity of the sickness, but it is still possible to get it. And then if it's still possible to get it, it's still possible to transmit it.
Mm-hmm.
Gotcha.
All right. Okay. Well, man, we thank you all very, very much for coming. And I know you have to get back to the hospital, so thank you for coming. We're out of time.
How about one round of final things? You got an audience. What do you need to tell us?
Sure. I think one of the things that's really important and I'm sure we've talked about it here, is please get the vaccine. We've talked about other medications that we give to patients, like steroids, and then there's remdesivir, the antiviral medication, and then there's monoclonal antibody you can get while you're in the hospital. It's monoclonal antibodies you can get outside the hospital. The actual data for that is in the hundreds or thousands. The data for the vaccine is in the millions. So you want to get
several millions.
Several millions, thank you. So it's the monoclonal antibody is one that you can get in the hospital. That's just one antibody. The one that you can get outside the hospital, if you're not sick enough to end up in the hospital, is 2 to 3. The vaccine mounts an infinite amount of antibodies in your own body. That is a natural antibody. No one has to infuse it. No one has to give you a pill. No one has to give you an injection. You are mounting these antibodies. So these are natural neutralizing antibodies your body is making all the time. And the vaccine that we talk about, mRNA, people are concerned, is it changing my DNA? Is there something that's altering my cells? Think of this like a copy of the actual booklet about the virus. That's all we're giving. It's like if I Xeroxed information and I gave you that paper, you read it, you shred the paper. That's all we're doing. We're not giving the virus to your body. We're not transmitting it. We're literally giving a copy of the playbook. So you give that to your cells, and say, that's what the virus looks like. I'm going to go ahead and make these antibodies. I'm ready to go. Then that information, that mRNA, is shredded and destroyed. It doesn't implant itself in our cells or in our DNA. It doesn't alter anything. And it's not new technology. mRNA technology has been in the mix for 10 to 30 years. I love that people think that we could come up with that in 18 months. I mean, it's amazing that you have such faith in human science.
I keep seeing 2002 is when they really kind of turned that spigot on.
Correct. This was actually thought of how are we going to help people with cancer? We're going to use a body against itself to help fight its own cells that are not listening. So how do we tell those cells, they don't have, these cells are cancerous? We're going to give information to those cells to say, these cells are cancerous, go destroy it. And that's where the thought process came from. So someone way more brilliant than me said, why don't we do it with a virus? We can tell the body the same concept. So it's absolutely safe. So I know people, and we're happy to give monoclonal antibodies for patients who qualify for it, who get COVID-19 in the outpatient setting. We're 110% happy to give it, and we're working like mad to make sure that we can give it and that we're staffed for it. But we would rather your body be mounting this response, that your body be making these antibodies.
Yeah. See, and that kind of goes, I can't help but think back to my comment earlier about that's truly fascinating that the body can do that, and the body is a very resilient machine, and the fact that you can go, all right, here you go. You don't like this, take care of it. And the body goes, all right. Yeah.
Exactly. I keep picturing the little booklet that comes with Legos, because, man, those blow my mind sometimes anyway. Just
makes me picture like in a movie, like the castle where the doors open and all the guys come out with the shields and swords going, and be like, I got you.
That's exactly it.
So,
get in your last bit of advice for all of us.
It's very simple. Get vaccinated. Please get vaccinated. Protect your loved ones, protect yourself. Please
and
get vaccinated.
and it's free. I mean,
It's
you can
free.
go to
It doesn't
Walgreens,
cost
Walmart, you can get them. Yeah. Mhm.
You can go grocery shopping and get your
Yeah.
vaccine.
Yeah. I've seen many people in line getting them at Publix. Yeah. And
Yeah.
so, yeah. All right. Well, again, thank you all so much
Thank
for your
you.
time.
Thank you
and,
for
and thank
what
you
you're doing
for
for us,
everybody
too.
writing in with the questions and everything. So I know we'll stop there. I know you all got to get back to the hospital. So thank you all very much. And thank you, Carrie, for helping us out over here. We really appreciate it. And I guess until next week, we'll see y'all.
See ya.
Pleasure.
Have a good week.
Thank you.